Dominic Tarpey. I'm here at Langley Porter. I'm on the committee that helps facilitate and organize this particular Grand Round series, and welcome to all of you. This is our first Grand Rounds for this academic year, and for this series, the Intensive Services Grand Round series for the Department of Psychiatry and Behavioral Sciences at UCSF. So our speaker is Lisa Kroon, who has been presented to our on this Grand Rounds in the past. So we're very happy that Lisa is available to talk to us today on a really important topic, not just for intensive services for inpatient, but across all of medicine and certainly psychiatry. So Dr. Kroon is a professor of clinical pharmacy at UCSF. She's chair of clinical pharmacy in the UCSF School of Pharmacy. She's also co-director of the UCSF Fontana Tobacco Treatment Center. And just a few other things before I turn things over to Lisa. We will be sending out a little brief survey at the end of this through Qualtrics, and you'll get that in your email shortly. And then we will also, of course, as with Grand Round series, offer continuing education credit. And this usually is at the end of the year, which will be approximately 11 months from now. So with no further ado, I will turn this over to Dr. Kroon. Thank you very much, Lisa.
Thank you so much, Dom. Good afternoon, everyone. It's a pleasure to be speaking at your first Grand Rounds for the year. And I think Nick's going to pull up my slides momentarily, but I've been asked to speak about pharmacologic therapy for smoking cessation. And really what I'll be doing is kind of going through each one and how to choose a certain treatment for your particular patient that you're caring for. And I recognize that tobacco treatment is not always top of mind as clinicians, but what I'll show is, as many of you probably are already aware, is that people with mental health conditions have a much higher prevalence of tobacco use, up to 50%. And in fact, is often what people die from is tobacco-related causes or conditions such as heart disease, other vascular disease. And so it's really important that we address this. And I'll close with showing you resources for this as well. So this is not something that you need to be doing alone. We actually have quite a few resources. So what I'm going to do is share my screen, and I'll do that right here. And so I'll assume people can see my screen okay. So here are my learning objectives for today. The first is for a patient, an individual patient, to assess any precautions or warnings for use of the first-line smoking cessation medications. And these will be the three classes of medicines that I'll be focusing on: nicotine replacement therapies, Bupropion, specifically SR, is the formulation that's been studied for tobacco cessation specifically, and Varenicline. And then for a patient, taking into their preference into consideration, initiate appropriate medication regimen, dose, frequency of administration, duration of therapy. Identify the two most effective smoking cessation medication therapies. Meta-analysis have actually identified 2 medications. We'll go through that. List 3 concerns for using ENDS or electronic nicotine delivery systems, i.e. e-cigarettes, vaping, and then to learn about how to refer patients for follow-up after discharge. Okay. Sorry. So if you have questions, you can go into the chat. It's a little difficult sometimes for me to see it, but I'll do my best to watch that as well. Okay, so everything I'm presenting here is evidence-based. It comes from the national guidelines for treating tobacco dependence in adults. And then all of the slides that you'll see here today actually come from a curriculum that we developed at the UCSF School of Pharmacy called RX for Change, Clinician-Assisted Tobacco Cessation Program. And the website is there. So you are welcome to go on to the website. There's a lot of additional learning and resources available for you as providers. And the slides are free to download and even edit. And they're all annotated, so there's lecture notes with them. So this just hopefully sets the stage for the importance of why you all, we want to be familiar and how to help people with smoking to become abstinent. This cites that about half of adult psychiatric inpatients are tobacco users. I wasn't able to get our current data at UCSF, but I'm quite sure it's close to that. And you can see things here like not using tobacco breaks as incentives. In the past, that had been done. Equipping users with coping tools, so learning coping strategies. So while I'm going to be focusing on the medications, the coping strategies are just as important for people to be successful to quit. Finding support from friends and family, and then of course providing cessation resources, education, and counseling, and I'll be touching a bit on that this morning. So this slide comes from our RX for Change psychiatry curriculum, which is also on there. This reads, it's a primer for psychotherapists. This was a handbook prepared in 1951 by a University of California psychiatrist, Dr. Colby, adjunct professor at Mount Zion Hospital, San Francisco, clinical associate. You could read that. And in this primer, it reads the following. Page 39, behavior during the interview. Should the therapist smoke during the interview? Why not? It will help drain the small amount of undischarged tension, which is always present during an interview, and it contributes to the naturalness of his behavior. So that was 1959. That's not our practice now, but can you imagine a day when that would actually be included in your doctor's handbook of whether you should smoke during your interview or not? So I'll be focusing today on the physiological component, the addiction to nicotine. And as I mentioned, the behavioral is as important, and treatment really needs to address both. But recognizing that you may not have time to do all the behavioral piece, this is where I'll be sharing with you the resources that you can refer your patients to as they're discharged for follow-up. So this quote comes directly from the Clinical Practice Guideline for treating tobacco use and dependence, and it reads, clinicians should encourage all patients attempting to quit to use effective medications for tobacco dependence treatment, except where contraindicated or for special populations for which there's insufficient evidence of effectiveness. And these special populations are pregnant women. With all medications, we try to avoid using medications in women who are pregnant. Smokeless tobacco users, the evidence is not as strong, and it just depends, how much chew or spit a person is using. But of course, someone could be addicted to nicotine from that route, and the medications would be indicated. Light smokers. So here the guidelines define a light smoker as smoking less than 10 cigarettes a day. And again here, less evidence of effectiveness of the medications just because a person may not have such a strong addiction component. And then similarly for adolescents who do also tend to be lighter smokers, the medications are not necessarily appropriate. So these are what are considered the FDA first line pharmacotherapies. So we have the NRT, nicotine replacement therapy, as I mentioned. So we have the gum, lozenge, and patch. These are all also available over the counter. But if you are to prescribe them for your patient, then they'll get covered by a patient's health plan for the most part. We have two prescription NRTs, the nasal spray and an oral inhaler, which I'll talk about, and these may be new information for you. We also know that many medical schools, pharmacy schools, nursing schools, that students receive very little training on how to use these medicines. And then the last two are Bupropion and Varenicline. So these are the medicines that we'll focus on this afternoon. This just shows you the timeline for the medications and the e-cigarettes as they came to market, just more for your reference. And so the Lozenge, for example, was introduced directly into the over-the-counter market versus prescription. Chantix came out in 2006, and those are the first e-cigarettes were sold in the mid-2000s. So this is a summary of effectiveness of the different medications. Please note that this is a meta-analysis, one of those network meta-analyses, and is comparing the studies of active drug versus placebo. So these are not head-to-head studies. I'll show you one a little bit later. But if you look at using a single medication, for example, the gum, Bupropion, patch, on average, using the medications double a person's success at quitting, which is really remarkable. Other medications, the patch and the nasal spray alone, again, roughly double. But what I want you to see in the last two rows there is the combination NRT. So using a patch plus a short-acting NRT and Chantix or Varenicline are in fact the two are the most effective medications, and really should be our first-line therapies. And so I will elaborate on that as we go here. What Dom will provide post this seminar is our RX for Change. We have a 2-paged pharmacologic summary guide, and I'm just showing you a snapshot of it here. And so everything I have is really summarized nicely on 2 pages that you can use as a little cheat sheet resource for you. So he'll send that around as we get going. So what's the purpose of the medications that we for treating nicotine dependence? And the rationale really is, which makes sense, is to reduce the physical withdrawal from the nicotine. And that allows a person to be able to focus on all of the behavior change they need to make, and not be going through severe withdrawal. Because if a person experiences severe withdrawal and then they're exposed to a trigger, whether it be coffee or being around friends who smoke, you're going to be more apt and tempted to have a cigarette. This shows you sort of the time course of withdrawal. And so here we have what are the actual withdrawal symptoms. And I like to ask a patient, how do you feel, when you have to abstain from smoking? So to really elicit from them what they experience. But you'll see that the gray curve in back is the incidence of symptoms. And you can see that after about a week, the symptoms are really peaking. And then they start to sustain over about a month, up to 12 weeks. And so when we look at NRT, you'll see that the dosing is higher during the first month and less over months 2 and 3. And that's because the symptoms should be lessening. For some people, certain symptoms may persist for months to years. And this is sometimes cravings, so just not necessarily a physical craving, but a mental craving can actually persist for longer. But this just shows you on average, for most people, the severe symptoms should subside within about a month. But there's, of course, some variance there. So I'll talk first about the nicotine replacement therapy medications. And this just shows you the nicotine concentrations for the different medications. And so often it's confusing for patients, well, if I'm trying to deal with nicotine addiction, why are you having me take nicotine? So I'll explain a couple points to that. One is the amount of nicotine is much less. And so what you see on the kind of aqua curve there, that's your cigarette, and it's time on the y-axis, nicotine concentration, on the on the main axis there. And, oops, 1 second. And so this is the cigarette. So within 10 minutes, you see really a bolus of nicotine there. This is moist snuff. And then all of the other curves and lines here are nicotine replacement therapy. And so this is all the oral medications. This is the patch, which eventually would just get to kind of steady state. But you can see that the level of nicotine is about a third, maybe up to a half of what you get from a cigarette. So using NRT, you're not going to feel any type of pleasure or usual sensation from that nicotine. The other big difference with the NRT is that it's clean nicotine, so 100% clean nicotine, and also we know exactly how much nicotine is in the NRT, and that's very different, for example, from the e-cigarettes. Okay, so with the gum and the lozenge, most people are quite familiar with the gum and the lozenge. There's two strengths, 2 and 4. And so a lot of people like the idea of the gum and lozenge because it's an oral substitute. So some people will describe that they really want to keep their mouths busy. So this is where you want to really take in that patient preference there. If they're having a craving and maybe it's not time for the next dose, they could take another piece of gum, and relatively inexpensive. And then the cons are that it does require very frequent dosing. So if a person's just using the gum or lozenge alone, they need to take 1 piece every 1 to 2 hours, and that can be really hard to adhere with. Both can cause some gastrointestinal side effects, such as hiccups, kind of heartburn. If someone has significant dental work, the gum may not be appropriate, or if you have TMJ, for example. So this is how you're going to be helping choose the therapy for that individual patient. I'm trying to find my arrow here. 1 second. There it is. Okay. So the gum is actually very unique in that you don't actually chew it like a regular piece of gum. And so sometimes when people tell me the gum doesn't work, I'll ask them, well, how did you actually chew the gum? And they'll look at me like, what do you mean, how did I chew the gum? I just chewed it regularly. And that's going to make the gum less effective. So in fact, what a person does is they chew it, and after about 15 chews or so, they park it between their gum and their cheek, and that's where the nicotine is getting absorbed, so across the buccal mucosa. And then after a few minutes, the tingling goes away, and then they start to chew again. So it's this chewing, parking sensation technique, and it's really important to go through that with people. Now the lozenge is simpler because, as you know, a lozenge you just suck on and then it just dissolves. So a person keeps the lozenge in their mouth, and after about 20 to 30 minutes, it'll dissolve fully. So some people like the idea of a lozenge instead. In terms of the dosing, again, on my little cheat sheet, it has all that. The dosing is that if a person has their first cigarette within 30 minutes of waking up, you would use the 4 milligram strength. And that comes from the Fagerstrom questionnaire. This is a tool that's used in more clinical research studies, that if a person has their cigarette soon after waking up, that is a sign of much more substantial dependence. So that's where that dosing came from. The 30 minutes, if someone says, oh, within 40 minutes, you could use the 4 milligram gum too, but it's just a guide. And then they would use that strength through their whole treatment. And so this shows you the dosing. As I mentioned, that first month or so is a higher amount of nicotine, so a piece every 1 to 2 hours. So this might be more the dose for your inpatients that you would be initiating your patients on. And then as they get out, increasing the dosing interval to 2 to 4 and 4 to 8 hours. So you can imagine if you had to chew a piece of gum or lozenge every 1 to 2 hours on a regular basis, because again, we're trying to prevent the withdrawal symptoms coming on, that can be quite hard for a person to adhere to. And that's where this combination therapy is so advantageous. With the patch, we have 3 strengths available, 7, 14, and 21. And I'll go through the dosing in a moment here. The patch is by far the most commonly used medication to help people stop smoking. It's very convenient. It's 1 patch a day, delivers a very steady amount of nicotine. But the big disadvantage is you can't titrate it. So if a person's having withdrawal, they can't just slap another patch on. It's going to take, as you all are familiar, a few hours to really kick into therapeutic dose. If a person has severe skin conditions like psoriasis, that might be a reason why you could not use the patch. So in terms of the dosing, this is just very general guide. So they define, the studies were done many, decades ago. A heavy smoker, more than half a pack a day. So a pack of cigarettes has 20 cigarettes. So if a person is smoking more than 10 cigarettes a day, you would start with the 21 milligram, and then use it for about a month. So the one brand that we have left in the United States is Nicoderm CQ. It was studied for that first step at 6 weeks. Other companies that are now generic had that first step at 4 weeks. Not a big difference, but that's just how they're labeled. So I generally use it the first step I just say take it for 4 to 6 weeks. And then you would go down. And then the light smoker is defined as 10 or less cigarettes. And so here you would start with the 14 milligram. And this is where guidelines differ from labeling of a drug. So I mentioned that the guidelines suggest for a light smoker that the medications may not be as effective. And so in this situation, if I have a light smoker, say, they say, I smoke 6, 7 cigarettes a day, I'll ask about the pattern of smoking. I do this also for the e-cigarettes or the vaping. Tell me, how do you smoke or vape throughout the day? If a person says, I have a cigarette, every 3 or 4 hours, and I need to have that. If I don't, I experience withdrawal. I will absolutely use medication and 14 milligram patch. Versus someone might say, it's only when I get done with work, I'll have 4 or 5 cigarettes in the evening. For that person, a patch may not be the best choice, and a short-acting nicotine replacement therapy would probably be more suitable. Now, we do have heavy smokers. You probably interact still with patients who are smoking 2 packs, maybe even 3 packs a day. These may be some of your older patients. And so the Mayo Clinic has a really nice protocol. The Mayo Clinic has a certification program for providers, and so this is widely available. I don't necessarily recommend starting this unless you have a lot of experience. But for example, if a person says they smoke 2 packs or more a day, so that's 40 cigarettes, the Mayo protocol would have you start with 2 21 milligram patches, so wearing 2 patches at a time. If a person smokes up to about a pack and a half, you might start with 28 milligrams, so that would be a 21 plus 7, or 14 plus 14. So just the point here is to really follow up with the person within a couple of days. The guidelines say within a week, but in an inpatient setting, you can do that within 24, 48 hours to see how they're doing. Is that patch enough? Maybe they need more. So that's really the important point there. So the last 2 NRT are the inhaler and the nasal spray. Now, these are not on our formulary, but you might be able to get the inhaler non-formulary. Most people are less familiar with this, but I'll tell you, I have a lot of our patients at the Fontana Tobacco Treatment Center who really like this. This is kind of a puffer. If you can see on the bottom screen here, it's a little plastic mouthpiece, and it has a cartridge. And within the cartridge is the nicotine, pure nicotine, a little bit of menthol. And so a person just puffs on it, kind of like a pipe, and it's invisible vapor. So it's not like the vaping from a Juul or other e-cigarette. It has no glycerin in there, so it's completely invisible, but it is a vapor. And so some people will describe that they really like this from that hand-mouth ritual, that they feel they need to keep mimicking that. Other patients may say, oh, I want to try and break that, and so they kind of don't like this. The inhaler, you would use one cartridge every 1 to 2 hours. So also adherence can be difficult if you're using it just alone. And unfortunately, for many formularies, it's a second-line agent and requires prior authorization most often, but it is a prescription-only medication. So for some Medicare Part D plans, over-the-counter medicines are fully excluded. The inhaler wouldn't be because it's prescription only. So the last NRT is the nasal spray, and I've actually, in my 15 years as a smoking cessation counselor, have only had a handful of patients elect to use this. Most people don't really like putting a spray in their nose. This one does have some unique side effects because even a person who smokes is not used to getting a blast of nicotine in their nasal mucosa, so they can get runny nose, tearing of the eye. With use, you develop some tolerance to it. If you have severe allergies, probably not a good idea either, but just something for you to keep in mind as an option. So the big take-home point here is that we are really big advocates of combination NRT. So similar to how you treat pain with a long-acting opioid, something for breakthrough, same concept here with nicotine replacement therapy. So we have the patch to provide a steady level of nicotine, and then on top of that, a quick-acting source of nicotine, gum or lozenge, inhaler, nasal spray, to use every 1 to 2 hours, but on an as-needed basis for cravings. And many of our patients, when I bring this up to them, is, I've never heard of this, I've never tried this, I think I'd like to try it. As I showed you, this is considered one of the 2 best treatment in terms of effectiveness. So I'll move on to Chantix, the second most effective treatment according to published studies. And so this is a non-nicotine cessation medicine. It's considered a partial nicotinic receptor agonist, and it's a pill. So some people, with all I've been talking about how to apply, didn't really go into how to apply the patch, but there's some counseling there. Taking a pill obviously is very easy. So how does Varenicline work? So Varenicline was developed specifically by the company as a smoking cessation medication. So it binds with very high affinity and selectivity to the alpha-4 beta-2 nicotine acetylcholine receptors in the brain. But it's only a partial agonist, so it has causes a low level of stimulant activity. And then it also competitively binds nicotine, which means if varenicline's in that site, nicotine's not going to be able to get in there to attach. So similar to all medicines, the varenicline works to reduce withdrawal symptoms. This is the dosing. I wouldn't memorize it, but know that it actually comes with a starter pack. I think from our pharmacy, you would just get the 0.5 milligram tablets initially, but the 2 main most common side effects are insomnia, excuse me, and nausea. So the dose is slowly titrated up just to make sure a person gets used to that. And then you get to the treatment dose. So the first 3 days, it's a 0.5 milligram in the morning. And then day 4 to 7, a 0.5 milligram twice a day. And then the real treatment dose is 1 milligram twice a day for up to 12 weeks. So depending on how long your patients are in the hospital, absolutely varenicline could be initiated while in the hospital, while the it takes the drug a little bit to get to therapeutic effect, because its half-life is 21 hours. That's not to say that a person won't be having some effect before that. So that's Chantix. Bupropion, I'll come back a little bit more with some comments about Chantix. Bupropion was not developed specifically, as you know, for smoking cessation, but in the depression studies, people who smoked reported less desire to smoke. And so there is a real reason for this. And it's because, as you all know, bupropion affects dopamine reuptake, unique from other antidepressants, affecting more serotonin and norepinephrine. So bupropion, because it affects the increases levels of dopamine and norepinephrine, that's why we think it has such an effect for helping people quit smoking. The dosing is a little different than what you might prescribe for depression. But if somebody's already, and the other point is obviously if someone's already on bupropion for their depression, you would never, increase the amount just for smoking cessation. But here's the dosing specific for smoking cessation. That's 150 milligrams in the morning for 3 days, and then 150 twice a day for the treatment duration. And again, with Chantix and bupropion, you want to start the treatment ideally 1 to 2 weeks before they quit, just to get up to a therapeutic level. So you've probably have heard about the boxed warnings for Varenicline and bupropion for smoking cessation. And the boxed warnings, in fact, I'll get to in a second, sorry. But the big concern, of course, with bupropion is seizure disorder. So being very cautious in using it in people with seizure disorder. So the boxed warnings were actually removed in December of 2016. So we're coming upon 4 years ago. And a lot of people I have found, providers, are still less familiar with this. And so when bupropion and then Chantix first came out, for Chantix, there were hundreds of case reports getting submitted to the FDA about changes in mood, psychosis, hallucination, aggressive behavior, and even suicide attempts. And so the FDA did put a boxed warning on it, as well as bupropion. Even though this was removed, I still do counsel patients about possible increased neuropsychiatric symptoms, but it's not considered a boxed warning anymore. And the reason for this is what's called the EAGLE study. So this came out in 2016. And Neil Benowitz, you can see there is the second author. Some of you may know Dr. Benowitz. He has retired, professor emeritus. I think back on recall, cardiologist, practices primarily at the General, is the world expert on pharmacology of nicotine and addiction. Anyway, so this study the FDA required to be conducted, and it compared Varenicline, bupropion, and the nicotine patch in terms of the neuropsychiatric safety and also efficacy in helping people stop smoking. So I'll just go through this briefly here. Very large study, 24 weeks, and so Varenicline, bupropion, the patch, and they followed people out for 24 weeks. So if we look at the neuropsychiatric safety data, and about 70% of patients had either mono or bipolar depression. The next most frequent condition was anxiety disorders. And then that was about 10%. And so you can see here in terms of the neuropsychiatric safety, and what was beautiful in this study is they did a placebo group. So head-to-head, 3 agents plus placebo. And if you grouped people by non-psychiatric versus psychiatric, yes, the psychiatric patients had slight higher prevalence, but you can see absolutely no difference between the study groups, with placebo even having 5%. So that was the data that the FDA was brought to the FDA to remove that boxed warning. And then just for completeness, here's the efficacy data. Interestingly, the patch was a little less effective than what we see in some other studies. Not sure what to make of that, but you can see that the effectiveness of these agents, we're not talking, with other conditions like blood pressure where 80% of people will respond. We're looking at cessation rates, often 20, maybe 30% or so. So that's just something to keep in mind. And then the last consideration here I would suggest to you all is to make sure with your patient who stops smoking. So upon admission, hopefully nobody is smoking, leaving the facility to go smoke, is that there are some significant drug interactions with smoke. So tobacco smoke contains polycyclic aromatic hydrocarbons, and these rev up certain CYP enzymes in the liver, and specifically CYP1A2. And so for medications that are metabolized through this pathway, when they're smoking, the metabolism is rapid, more rapid. And then upon cessation, that effect on the upregulation of CYP1A2 goes away, and then the metabolism will be a little bit less, causing increased drug levels. So just an important consideration to keep in mind. I have caffeine starred here. Caffeine's clearance is increased 56% when a person smokes. And so we actually do assess for caffeine use and recommend a person cut their caffeine in half if a person, when they stop smoking. This table is available on the RX for Change website, so you can take a look at the more complete list. But a couple drugs to call out is clozapine, and then what I don't show you there is olanzapine, or Zyprexa has some significant interactions in that if a person is smoking, the olanzapine levels can be reduced by about 12% or so. Okay. And this just shows, this is just another analysis of cessation rates. The yellow bar is active drug, the gray bar is placebo. And again, you can see roughly that compared to placebo, the medications double to triple a person's success at quitting. So I thought I'd finish up here just a little bit on the ENDS, electronic nicotine delivery systems, and the EVALI, or the e-cigarette or vaping product use associated lung injury. So before COVID hit, there was a lot of attention about EVALI. You hopefully had heard about it in the news, but as of earlier this year, we had thousands of cases of hospitalizations for lung injury as a result of ENDS and even death. Many patients have reported using primarily THC, but some were just smoking nicotine, but perhaps less of a risk, but we don't know. And probably the vitamin E acetate present in some THC containing vaping products is the chemical of concern. It's very viscous, lipid, clogging pulmonary airways. So a real concern, especially among our kids and teenagers, and some data to actually suggest use of e-cigarettes separate from the lung injury increases the risk of heart disease. And some seizures have been reported to the FDA. So a bit of a stronger stance on the health effects of ENDS, or electronic nicotine delivery systems. And bottom line, we really don't know the long-term effects. So as clinicians, we do want to screen for e-cigarette use. Specifically, we're talking here about nicotine use, because a person can absolutely have addiction through them. Until more safety data comes out, we really should not be promoting them as a safe or a safer alternative to smoking. We're really not sure how effective ends are in smoking cessation. There have been a couple studies, a couple from the UK and New Zealand, but the source of the ends are regulated in those countries, so very different from the US. So we do not want to recommend them for people who definitely not as a smoking cessation benefit. And then, so I just say here, it may have a role if someone's really insistent on using vaping instead of smoking. That's a different scenario than saying what happens for many patients. Unfortunately, they become dual users. They start vaping because they can't smoke, let's say, an indoor in their apartments in the city. And many people will actually describe they're getting probably more nicotine than they were before they started vaping. So not an alternative for smoking. So in conclusion, before I go into how to refer your patients to us, what we've actually done studies and shown that most patients don't use the medications properly. They underdose. For example, I've asked people, well, how many pieces of gum do you chew? And they say, oh gosh, I chew 5 a day. Well, we know you have to chew at least 9 or 10 if you're using it alone to really be effective. Or people stop the treatment early. And I saw a question in the chat there. So yeah, most treatment duration is 3 months, but that doesn't mean you can't go longer. And so that's just a guideline. And so you could feel comfortable using the treatment for more than 12 weeks. I see Aaron's question there. So it's a guide, but if a person's using combination NRT, for example, and they say, hey, I'm not feeling ready to stop it, I want to continue using it, absolutely. Any risk of using these medications far outweigh the benefit of not smoking. I'll just, since I've got the chat box open here, comment on other combinations, like Varenicline and Bupropion or with NRT. So thank you for that question. So Bupropion has been studied with NRT, and it is FDA approved in combination. You get just a little bit more efficacy with Bupropion plus NRT. So fully, that would be fine, and I would use combination NRT plus Bupropion. The other question with the Chantix, Varenicline and Bupropion, it's not FDA, they're not FDA approved yet, nor with NRT. So Varenicline has been studied with NRT. Some of the results are mixed, but probably we'll see approval come out. What we've done at the Fontana Center, and I know what Mayo does with Varenicline, if a person, because theoretically you are blocking those acetylcholine receptors, so there'd be no place for nicotine to bind. And in fact, when someone is on Varenicline and they smoke, they'll say they don't feel any pleasure from that because the sites are blocked. But theoretically, they're probably not 100% saturated. And so some people do describe that they like having the gum or lozenge on top of Varenicline for situational urges. And absolutely, we'll send the slides out. I'm happy to do that. So just again, really focusing on appropriate dosing, a full treatment duration. All the NRT comes with boxes that are intended for over-the-counter use. So please read the directions and then assist with any kind of copay or challenges with that. So in summary, we know that many people struggle with stopping smoking, and it's such an important role for all of us as providers. Using medication plus counseling, most effective, and then Varenicline or combination NRT. I will say with the Varenicline, I spoke to our primary providers grand rounds earlier this year, and with Chantix, I absolutely say, if your patient is under the care of a psychiatrist, psychologist, or therapist, definitely need to loop you all in so that you're aware that medication is being started. So as Dawn mentioned, I co-direct the Fontana Tobacco Treatment Center along with my colleague Suzanne Harris. We have counselors, Suzanne and Carol. Radhika Ramanan is a physician, primary care physician, and so patients can also be referred to her. So we have one-on-one smoking cessation counseling. She's doing all video visits now. Our stop smoking classes are unique from others in that we do it on a weekly basis for 4 weeks. So 2 hours on Mondays, usually now. We've also converted everything to Zoom. So Mondays from 5:30 to 7:30 for 4 consecutive weeks. That's our curriculum. And then we also, on the same time, so we're alternating these, we have a support group. So for people who have come through the group counseling or even not, we provide a lot of telephone counseling. If someone wants to come to the support group, they can. And that's on Mondays as well. So how to refer in your orders, we have e-referral. So you just type tobacco, smoking, Fontana, and what will come up is the AM referral to Fontana Tobacco Treatment Center. And then that'll go into our queue, and then Suzanne and Carol will phone them and actually do some counseling. They'll do an assessment, do a group class, does that suit you? Would you want one-on-one with a physician? And the other big resource to be familiar with is the California Smokers Helpline. So they provide telephone-based counseling, specialized, counselors, high quality. In San Francisco County right now, Medi-Cal patients can get a 2-week supply of the patch free. And so that'll also show up in your orders if you just type tobacco or smoking in an AM referral. So you'll see that too. So just something to be familiar with. Okay, and I think that might be my last slide is here. And then just a couple other websites that might be, these are also patient-facing websites. Become NX, that's operated by the Truth Initiative and the Mayo Clinic. It's just an outstanding resource for patients. And then National Cancer Institute is smokefree.gov, which also has a mobile app. And there are other mobile apps coming out there, but I think these are 2 good website resources to provide patients specifically. So that's what I have. I see Dom. Are there other agents being researched or developed for specific NRT use? I'm not sure I follow that. So right now, the NRT indication is only for smoking. It's not for other sources of nicotine like e-cigarettes. But as I said, if your patient does express real addiction, the NRT could absolutely be used. But unfortunately, there's no dose guidelines yet. And in fact, my colleague Robin Corelli and I are working with the California Smokers Helpline to develop a protocol of just how to dose NRT in a person who's using ENDS or e-cigarettes. So Dom, I'm not sure I answered your question. Okay, any other questions? Maybe I'll stop my sharing. And I can see the chat box a little easier.
Lisa, I'll just come off mute. I was just thinking more in terms of just additional medications along with the ones that you presented on just for tobacco cessation.
Nothing too exciting. I mean, they've actually looked at a vaccine. I'm not familiar with anything super exciting coming out. Neil Benowitz, he has done studies with low nicotine cigarettes. So a fading or tapering way. And so you might see those come out. And that's different than just smoking fewer cigarettes. Because what a person does if they're trying to cut down, you can change how you smoke. So maybe you only smoked half the cigarette and put it down. If you're tapering, you're going to get down to that butt. So because the body is going to try and maintain that nicotine level. And so what Dr. Benowitz and others have looked at is a low nicotine cigarette to actually help people cut down their smoking. So yes, so for chewing tobacco, absolutely can be effective. And the Mayo, actually, if you're interested, has a protocol on chew, looking at the type of chew, whether it's Skoal or Copenhagen, and then how many cans a person chews. But again, I don't get too hung up on that. I really ask, well, how are you chewing? How frequently during the day? And when you can't chew, are you exhibiting withdrawal symptoms? And if a person is, I would feel very comfortable prescribing pharmacologic therapy. So the next question is the issue of transfer of addiction from smoking to NRT. And you have one patient admitting, yeah, it's very uncommon, I would say, to actually transfer the addiction because the amount of NRT, nicotine in NRT is much less. And so it may be more psychological, I don't know. So I'd be curious how many lozenges a person is using a day. But again, that's the risk benefit. So would you rather having someone on lozenges for years than smoking? I would say that the benefit of not smoking far outweighs. And that's really what like Sweden, other sources of nicotine is called snus, and they have a more harm reduction approach versus an absolute abstainment. Okay. Well, then Aaron has, it won't tell me, but it's a lot, exclamation mark. I think if he's really, or this individual is really abstaining from tobacco use, there's really no harm in keeping on the nicotine lozenges, in my opinion. So, any other questions? So, okay, to us, also an anecdote. Yeah, it can happen. I would just say it is unusual. And so some people do like having lozenges or gum or inhaler around just for situational urges, even if, it's years out from stopping. For COVID-19, and with tobacco use, so there is data that the other comorbidity of increasing severity of COVID disease is if you do smoke tobacco. And so there is some public service announcements reaching out to people who smoke, that this might be a good opportunity or good time to consider stopping, because if you've got COVID, your risk for having more severe disease is higher. And so we've sent some of that messaging out actually to the UCSF Health COVID hotline for patients. When they call, they are asked about their tobacco use because of the risk. And we were able to add a question of, would you be interested in talking to someone to help you stop smoking? So we're getting some referrals to the Fontana Center through that route now. And so I'll just offer up, you have my name. If you have a question, I'm happy to answer by email. Hopefully you can see, it's hard by Zoom, how much passion I have for this. I think as you start to help people stop smoking, it's actually really fun to do, and probably, as I said, one of the best things that a person can do for their health. So hopefully I've just maybe, triggered some excitement in all of you this afternoon. So thank you so much for your time.
Thank you, Dr. Kroon, and thank you, everyone. And we'll go ahead and end the meeting and get the slides and the questionnaires and everything out to everyone shortly via email. Thank you so much. Bye-bye.
Thank you.